Hi, I'm Dr. Abdulhadi, the USMLE bro. In this video, I will present a case about euglycemic DKA diabetic ketoacidosis. So let's go to the board. This is a case of a 52-year-old male patient who has history of type 2 diabetes, and they will probably say he is on this and this medication and also on an SGLT2 inhibitor. Let's say in this case he is on empagliflozin or Jardiance. The patient presents to the emergency department with shortness of breath, and when he arrives, he was noted to be tachypnic with a heart rate of 30, with a respiratory rate of 30. So once you see that shortness of breath, your mind will be thinking of what could be from the causes of shortness of breath that presents to the emergency department. But don't worry, because I will guide you through how to read the exam question, because in every point in the paragraph, they will give you something to rule out one of the diagnoses. So they will tell you the patient is tachypnic, but the other vital signs is normal. And the O2 saturation on room air is 99%. And you're already like, what the heck is going on? Why is his O2 saturation 99% and he's short of breath? They tell you he had a recent flu and he's getting better. So they listen to his lungs and there are no additional sounds, normal breathing. There's no rales, there's no crackles, there's no wheezing. And they checked his labs. Basically, the complete blood count, every other basic lab is normal. The patient doesn't have anemia, but it was noted that the bicarbonate was 5, which is very low. They also tell you that the patient hasn't traveled, no trauma. So you see they're telling you that it's not a PE, and the D dimer is normal. The blood glucose of the patient was also normal, and they did an ABG that showed evidence of metabolic acidosis with respiratory compensation. They tell you like his PCO2 was probably low, maybe about 25-ish or something like that. They did a chest x-ray, which is normal. So by that time, you know that it's not a pneumothorax, it's not a pneumonia, it's not a PE, that what they're talking about. It's not COPD because the lung examination was normal and the patient was not wheezing. So they will tell you what is the next best step in the diagnosis. Is it a CTPA, which is a CT pulmonary angiogram to rule out pulmonary embolism? And you say, okay, well, this patient has a low well score, he has no risk factors, there's no leg swelling, and the D-dimer is normal, so this is the wrong answer. Is it a troponin? Well, the patient didn't have chest pain. And they will also probably throw it in there that the EKG didn't show any ischemic changes, so troponin is also eliminated. Is it an echocardiogram? Well, the patient didn't have any crackles. The x-ray is normal, so I don't think this is a congestive heart failure, so I will also eliminate the echocardiogram. The correct answer in this case is beta-hydroxybutyrate, because this is a case of euglycemic, normal glucose, diabetic ketoacidosis, which happens in patients who are on SGLT2 inhibitors when they are under certain stress, a recent infection, surgery, any acute illness that is happening to the body. This is a very important concept, and you guarantee it that you will get this question on the exam. The euglycemic diabetic ketoacidosis is when you see the blood sugar like 160, which is normal, and you see the blood is acidic, so the bicarb will be something low, like 5, 6, 3. And when you do the ABG, you will notice that there is a metabolic acidosis with respiratory compensation, where you find the PCO2 being low because the body is trying to breathe fast. Therefore, the tachypnea, and the shortness of breath. The treatment of euglycemic diabetic ketoacidosis that occurs in patients who are taking SGLT2 inhibitors is very similar to the treatment of the regular DKA. So the regular DKA and the euglycemic DKA, you both want to hydrate those patients and make sure you correct their electrolytes. The only difference is that in DKA, the blood sugar usually is like 500, 600 or something like that. So when you start the treatment, you actually give them an insulin bolus and then insulin drip or insulin infusion. In this case, you should not give them an insulin bolus because the blood sugar is low and you can cause hypoglycemia. So you jump immediately to the insulin infusion. If you like this content, please hit the like button and follow me. I also have a YouTube channel. You can see it in the bio and follow me there as well. Thank you so much.